to keep this very simple. Hydrocephalus. For those of you who speak Swahili, water is maji. And if you got water in the head, you'll be called what? No. For hydrocephalus is kichwa kilicho ja maji. Excuse me, I know I'm from the lake, but I know one or two words of English or Swahili. So hydrocephalus, water in the head. It now set up here, as we were told earlier, they grow to huge sizes. It's usually associated with some complications. It's usually associated, especially in the pediatric age group, with congenital malformations. Those are the incidences. In our figures, this is what we need to work out in terms of what to work out. It's supposed to be a bit worse. Those are the causes. The infections, most of them are meningitic. And the meningitis is quite prevalent. We have them with following upper respiratory tract infections, things like those. I mentioned myelomeningocele. We've got a high rate of myelomeningocele, this part, spinal dysraphism. There is an association with poor nutrition in the period between implantation, that is the first 28 days before the neural tube closes. So if you are poorly nourished around that period of time, it is higher. Subarachnoid hemorrhage, of course, following trauma or following aneurysmal subarachnoid hemorrhage. The tumors that sit in the posterior fossa and the ones that sit in the third ventricle, all of those can give you hydrocephalus. Samuel, get away. I want you to quickly rattle how CSF circulates. Can someone give me a mic? Rattle it out quickly.
Yep, you can. Right back up. Don't say
So it's produced at the choric plexus within the lateral ventricles, flows down to the third ventricle through foramen of bone groove, then goes down to the fourth ventricle, and then
he's getting softer and softer. Then he's thinking on his feet or on his seats.
No, sorry, I have a cold.
So, excuse.
So from the fourth ventricle, he goes down either to the two lateral kinds of Lushka and Magenti, and then to foramen magnum. Yeah, and then it gets reabsorbed through the arachnoid process of the sagittal cells.
That's right. Now, anywhere along that path, you can get blockage. When you get blockage, there's a buildup. I put that picture there. See a lot of this. And you can imagine a child like this being born, child with a big head, child with a head that is big, and myelomeningocele. It's a nursing issue. How do you treat this child? The head is getting bigger. People are scared of bringing them into hospital. And of course, it has its intermediate to long-term complications. And if you look at the disease burden as to what somebody is born like that, especially when they have a myelomeningocele, the signs of infection, the problems with urinary tract infections, weaknesses, and I think in a resource environment where things are to be looked after, they'll have pressure sores, and most of them do not survive. Unless you've got a situation where you've got a caring family and there's a lot of support, treatment of this can be done. I think the residents know that these are some of the things that they cut their teeth on in terms of surgical procedure. You are taught how to make sure that you have proper dural closure and CSF does not leak. Who's the next one? Who's the resident? No, Sam. Oh, these two. Oh, yeah, fine. It's Lydia. Is it Lydia? That's an image there. Tell me what you think about that scan.
There's dilatation of both the lateral
What are they doing? Look at that. They want to make me walk.
Sorry. Is there indication of the lateral ventricles, both the frontal and temporal ones, as well as the third ventricle?
Just say it again on points so we know what they're talking about.
Yes, there's the indication of both of the anterior horns of the lateral ventricles, as well as the temporal horns and the third ventricle. So most probably the point of obstruction is distal to the third ventricle or at the aqueduct.
What else do you think about the frontal horns?
There's periventricular hypodensities.
Okay. Now, do you watch cartoons? Or do you ever draw cartoons? Or when you were younger, did you ever watch cartoons?
They look like Mickey Mouse with ears.
Thank you. I find that very exciting. Simply because you have to have a pattern recognition. And if you do not see a pattern, you don't get it. My daughter is an animator, so I think of cartoons most of the time. What about that? The next, Nicole?
So, this is just the occipital lobe guided essentially part of the temporal, and this is
You are shaking more than you're talking. So what are you doing? Are you not shaking or both?
I was just watching. I looked at it the same continuation of description. This is the part of the lateral ventricle, the posterior horns, which is dilated. The image is not symmetric. It's not tilt. You can prove it from here. I think it's posterior occipital horn, which is dilated, and we have this continuation of almost. So we are almost in the.
We already had vertical. You have said c'est en français.
Third ventricle going.
That's third ventricle.
We get fourth ventricle and.
So is it third or is it the fourth?
Fourth, because we are level of orbit is fourth now.
What else can you tell us? And those CSS sources.
This is the system. It's a system which is also.
Now you see why I do this? It's because at this time of the day people fall asleep. And if you are thinking about what you're doing, you remember and you access the medial part of the amygdala when you're getting excited and scared and thinking, what the deal is happening? You will remember. And everybody else will remember that you are talking and shaking more than it's useful. Khalif, that's piece of cake. Give us Khalif. This is a cake. Kichwa kilichojaa maji, not kichwa maji. And the pointer? You want to see how much it's shaking also.
So those are the
dilated ventricles, bilateral dilated ventricles, and lateral ventricles. So this is hydrocephalus, basically. Maximum hydrocephalus.
And that one's when you're at it. What image is it, and what view is it, and what are you seeing, and what are you pointing at? Chop chop.
It's a sagittal view of an MRI. It also shows.
Sagittal view, which sequence? Chapati sequence.
No, T2 image with dilated lateral ventricles.
And what else? So what do you think? What would be the diagnosis on that one? Lateral ventricles and
the third ventricle.
And what else? So what's the diagnosis?
Aqueductal stenosis.
You should say it all, don't you? Yeah. How to manage it? Pharmacological. I think it's as a saving maneuver, we sometimes use a sinusoid diamox. And everybody thinks about shunts, and yes, we are now doing third ventriculostomies. Same thing, neonate, thin skull, huge anterior fontanelle. Pressure sores can come in from the legs. Have to be very careful. Pressure sores, not pressure sores. Pressure sores can come through quite easily. And when you think about having to shunt something like this, complications can arise. Talk about extra humongous mega hydrocephalus. I left this child's eyes open because so you can see a significant sunset. It can get to that stage. That child's head circumference was 93 centimeters. When you're putting in shunts, I see natural eyes here, and we know that there are some tubes that you pass through the skin underneath, so that you can have a subcutaneous placement, and it's useful to have those with you, so there is easier placement routes. The complications, and I think this is where we have problems. In terms of when to put it in the shunt, you can have the immediate ones. I notice that sometimes, especially in our institution here at Jaramogi, shunts are put in without proper due attention in terms of what the pathology is, 1, 2. Sometimes you might see a big head, and I think the residents we went around with, we saw a child with a big head, but it was not related to a big ventricles. It was because of a big skull. So you not only have to have the images, you have to have the appropriate history, and you examine the patient. So when you have the immediate complications, it's usually on shunt placement. And infection is the thing that will cry about most. When you're putting in your shunts, I'll ask, is that Matilda? Matilda's not here. It's Matilda. Now, these are the nursing staff who always look after us. And I utilize that term quite a lot. Sorry, Matilda, I'm going to put it up on the carpet here. Who of you know about Harry Belafonte? Who has heard of Harry Belafonte? Who has not heard of Harry Belafonte? You have not heard about Harry Belafonte? You have not heard about Harry Belafonte? I will educate you. Harry Belafonte is from the Caribbean, calypso singer, and he sang along with Benny and Makeba on Malaika, and he was quite useful at the time that we're having our independence. He was quite important. But he sang a song about Matilda. Aha! My senior colleague is member. I'm saying this just because I'm trying to say that I can sing. So I don't call Matilda, I always tell her, Matilda, Matilda.
Sing a little louder.
Matilda, she took my money and money. So now, Matilda, when we have the shunts put in, give her a microphone. Give her a microphone. When we have the shunts put in, and what are your concerns in the operating room?
Shunts are usually put in when, in cases of hydrocephalus.
And what time of the day would you like the shunt to be put in?
In the morning.
Why?
In our setup, morning where all members are there. All the team members are there.
She's giving the right answer, but for a slightly different reason. Morning, because it's the first case. Morning, because you have the blood count is the lowest. And the other thing that we need to do as part of the checklist, if there is a shunt to be done, you decide who is in the operating room. Everything must be there before you start, and nobody walks in and out. When I'm putting in a shunt, you don't walk in and out. If you walk in without permission, you can have issues. Immediate early days, complications. So the light ones, we talked about it in terms of pressure source. Some shunts can block, some of them can come through the skin, especially the thin skin like we have seen, and so on. Most shunts block within the first 60 days. If the pressure has been there for a long time, they can lose vision, pressure source, and further neuronal damage, as we've said. The next topic I'm just going to run through it because we talked about antimicrobial shunts. I noticed when you came across, you have some shunts that came through the external ventricular drains that had antimicrobial impregnation. that's talking about the same thing, how shunts can give you problems, especially in the neonatal period. So it would be useful to have these, and I'll tell you why. The second thing is, if you have the principles of when to put in the shunts, with those protocols, you minimize the rates of shunt infection. It is reported, and this is data from Kenyatta, and also from Nyeri, that our shunt infection rate is up to 30%. It should be less than 1. So Roger Baston from Nottingham did this, and he said most of the strains of the bacteria are found for the first 6 days. So bacteria are quite naughty. If it takes about 48, 52 to kill, for them to be killed, and if you add the extra 2, this shunts impregnate which are impregnated with the bacticille, it reduces it. Now, our friends are from North America, so we can utilize some of their data. And that tells the cost implications of a shunt infection. Look at those figures. If you look at $78,000 as compared to benefit of about $50,000, it's a lot of money. The shunts that we use here, Shabras shunts which are made from India, cost about $50? Yeah, it's about 4,000 shillings, 5,000 shillings. Some of the bacticille shunts will cost you about what, 80? It's 45,000 shillings. So there's a big difference. So it reduces the shunt infection rate. However, we need to get our systems in position to reduce it. So one of our ML students, Kitungu, looked at work between Kenyatta and Nyeri, and the idea basically giving us some of the figures. Most of them were in the pediatric age group, between 25 to 30% infection, more of them being neonates. But he put in the basis for a shunt registry to be done. Our colleagues across in Uganda are more advanced, because in Bale, Cure, and some work in Mulago are bringing out their figures. But in Kenya, it's in Kijabe where they're doing some of that. And I think it's prudent that I think if we start working off from Kisumu here, we try and coordinate nationally so that we can get a shunt registry, to have a note as far as how these things occur. I put this slide up for idiopathic normal pressure hydrocephalus. Professor Joe was here earlier. He referred me a couple of patients with idiopathic normal pressure hydrocephalus. Just rattle through this because it's in the more in the mature age group, and just first seen sporadic cases from 1935 for Penfield. Penfield is one of the inventors of instruments, and then Hakim is a person who has made shunts and introduced this particular concept. So it's a gait disturbance, memory impairment, and urinary incontinence. It's like a triad. When you see those, and have a secondary insults, like has been mentioned there, and of course in our setup with significant head trauma and tumors which have been picked up, and of course CNS infection, it is possible to have secondary normal pressure hydrocephalus. Those are the incidences, and I see Dr. Wutu is here, so if you're quoting German figures, I hope he doesn't mind. But it's about 0.9 to 100,000. Main problem really is absorption through the aeroplane villi, that's where things are stopped, and that's the pathology of physiological mechanisms. So, how to diagnose? We've got all of those things here, really. We can do all that here. Except isotope sonography, some of it can be done at a hospital in Nairobi, but ICP measurements and CSF dynamics, if you've got MRIs, those can help. But CSF removal is the mainstay. So if you recognize the classic triad and look at the other differential diagnosis, you can rule that out. That's somebody in the lateral position, and when you put in the pressure monitoring, that's the level that you take, and you can put that for transduction, that should be normal, and that's a scan of somebody with normal pressure hydrocephalus. And if you look at somebody with a higher level of those extra waves coming through, that pattern will give you normal pressure hydrocephalus, and you take off CSF. That gives you a supplementary test that you can do, and we've had a reasonable experience with putting in shunts for patients like this. One of the patients we looked after from Kisumu has what we call a programmable shunt, so we can actually change the pressures of the shunt percutaneously, but that's not the usual way of treatment. So guidelines of management for the residents, you can look at that as how to read it up. So risk benefit, really, if you have your mature parent beginning to lose balance, getting more demented, and have urinary incontinence, please remember this. Follow-up is important, and you have to manage complications like we do for Shunts. Not asleep yet? ETV. In Kenya, I had the dubious honor of being the first person to do endoscopic third ventriculostomies, and I used a pediatric cystoscope. I mentioned this yesterday, that the central nervous system and the urological nervous system have got some similarities. We had the use of a focated balloon catheter, and I thought I was being clever by using a bronchoscopy forceps, because it was going to be useful. But at that time, it was really Ben Wolf who did a seminal work with all of this, over 1,000 cases, and I think it's been quoted throughout literature. Although some of his figures, including endoscopic third ventriculostomy, and he would go ahead and do choroid plexus coagulation, have been a benchmark for how ETVs are done around the world. In our country, we use the Shizo-Oi endoscope, and the Shizo-Oi endoscope, it looks like a gun. It is so we had the privilege of meeting him in Lyon, France in 2006, and he has visited with us, and that is the endoscope that travels around. We'll show you some figures with it. I mention that because Peter Onyeke, who is here with us in the audience, is part of the team who we walked up Mount Kenya to raise funds for the first neuroendoscope. And this was done by the Neurological Society of Kenya. This scope traveled around the region to do endoscopes, especially patients who had acute stenosis. DEC reported how to use the forceps, and in the year 2000, so I was actually vindicated, so I could be able to use it. So that was our watershed here, IFNE, International Federation of Neuroscopy, Lyon, France, 2006. Peter Onyeke was up there, and he met Jose Piquet and Shizo-Oi. These names keep coming up because in terms of development of neurological surgery locally, they have come in quite useful. Peter, I didn't take your photograph, I took you out, I cut you out. Yeah. Now that's on top of Mount Kenya. That's the last few glaciers left. So, if you don't plant trees, even that is going to go away. That is Jose Piquet with Ruben Paul Lubanga and Patrick Akuku Okoth, and that's Mulunga being shown how to do neuroendoscopy. That's a course, and that's Mahmoud Qureshi doing some of those first neuroendoscopy things. Now, if you look at that person's head there, it is trans-illuminating. That's the kind of test that you use for a thin scalp. It's so thin, you could be able to do it because it had a very large fontanelle. The mobile telepath was used. Although we bought towers here, and that has been utilized. Peter Onyeke actually used the endoscope in Nairobi, and the endoscope is here. So you've got 3 patients there's one who's got a cyst in the third ventricle, giving hydrocephalus, and there's somebody who's also an arachnoid cyst, we shall use this scope for. That's the same thing. Now, when you see that there, that's a telepath, that's a tower that will be portable, but we have a tower now, which has been bought for Yeremogi, so we use that. Now, just to have an idea of what it looks like down the endoscope, the white tube that you see here is a covering of it through the brain skull. And that's the skull base, the floor of the third ventricle. You can see it pulsating. There's the branches of the plasma artery. You can see it pulsating quite clearly. Now, in terms of the route that we use, we tend to use a precoronal burr hole. That is the infundibulum of the pituitary gland. The technique for doing so, you need to have hand-eye coordination, and we have learned using the Shizo scope, we rest it on our side, so when you're going in, it's more stable. You shall see that we'll introduce refocusing. Let me just keep it along. You can see the pulsations quite nicely. The skull base, on the floor of the third ventricle. So that's the focusing catheter being introduced. We make a hole through the floor of the third, and we use it's about 0.1 mils to expand it. As it's been expanded, the things that we worry about deep to that is the basilar artery, the perforators, and so on. That's the tube being blown up. The procedure itself, skin to skin, takes about 20 minutes. Because you have proper dural closure, that's the focus of balloon caps are coming up. And this is where the nervous resident is the one who's blowing up the balloon, and if he blows it too much, then you can clobber it, but you can't at that time since you've got the scope inside the patient's head. And then once that's done, at the equator of it, you're supposed to be able to look inside, and with that you can barely see. Try and squeeze that further to make it wider. We sometimes use a guide wire in this to be able to assist in it, to speed that along. And once that goes enough further, when it pulsates like that, it's likely to remain clear. So when you introduce that which you see there, that's part of the skull base, and the iliacus membrane is part of that white. Oh, it's gone back. I'll just get the last bit there for you. Excuse me, I stopped it short. I'll just speed to the end, and then you will be able to see where the basilar artery is. There it is. That's the pipe at 6 o'clock. That's the basilar artery. Once you've seen that, it's very clear. It's sorted. Complications, dermal neuronal structures. When you go into watching you get to the phonics, hemorrhage, of course, infection, CSF leakage, and death is one of those. So the hormones that tend to be affected are ones from the pituitary axis. And of course, any neurological damage if you have affected the optic nerve on the way through. Now, Africa has its challenges. Now, that picture is a real one. This was done by Mr. Qureshi's father. He used to be a drug rep, and when he was, that was his car. He was coming through from Mombasa, and he had kept bananas in the back seat. He had gone for those call of nature. There are no stops along which to allay for him to relieve himself. So when he went, on his way back, he saw the elephant trying to take the bananas out of the car. So he decided to keep it in the bush, but he took the photograph of the elephant. So that's Mr. Qureshi's dad doing that. Part of this development, and I keep saying this, that we need to have collaboration. This was the course that was held in Mombasa. The people who you see at the front there are all World Federation. I'll use the word big wigs. Mr. Qureshi is there in the center. That was the WFS symposium in Mombasa when they inspected their facility to be able to allow them to do neurological surgery. It is my prayer that in 2020 or next year we shall have such a gathering to do such a thing for us, so we'll be able to do all of these things and start training people here. More so, we also have women in neurological surgery, and that is the Minister for Health in Coast Division. I say thank you, and for those who will be going to Amara, I hope you'll be able to see one of those. That photograph was actually taken in Amara. That is not a leopard, it's a cheetah, the fastest land animal. It can operate at about 100 kilometers per hour, just short of 62 miles an hour, for a short burst. And it's camouflaging quite nicely, looking out the planes to be able to attack. So if you're early enough and you're lucky enough, you will see one of those. Thank you.